Okay, hi everyone. Good morning and welcome to the virtual International Symposium on Dignified and Compassionate End-of-Life Care organized by the Action Research for Community Health Laboratory Arts Lab of the School of Social Sciences, Nanyang Technological University, Singapore. So my name is Paul, PhD student at the School of Social Sciences and also the doctoral researcher of the Family Dignity Intervention Research Program and also today's host for our wonderful panel discussion. So I would first like to acknowledge and express my most sincere thanks to the Ministry of Education Singapore for their generous support with this symposium, as well as with the empirical research program of the Family Dignity Intervention, FDI, that aims to strengthen evidence-based and holistic palliative care services within the local context of Singapore. I would also like to express my deepest appreciation to the Palliative Care Center for Excellence in Research and Education, PalC, for hosting the symposium, to our wonderful plenary speakers for their wonderful scholarly contributions, and to all of you, our participants, for your amazing enthusiasm and interest into this series of webinars that really focuses on understanding and supporting the needs of patients and families facing the many challenges of death, dying, grief, and bereavement. Now, over the last few days, we have heard and learned from four of the most prominent and renowned scientists and clinicians who specialize in dignified and compassionate end-of-life care research and practice, all along the continuous trajectory of pre-loss palliative care to post-loss bereavement care, through knowledge transfer that emphasizes evidence-based practice, as well as opportunities for clinical networking and collaborations. It is our hope that this symposium will create a positive paradigm shift that enhances and augments holistic palliative end-of-life care in Singapore, Asia, and around the world. Now, unfortunately, we are on the last day of our symposium, and all good things like a life well lived have to come to an end, right? So, as your host, I hope to do so with as much grace and eloquence as possible. And for today, we do have an interactive panel discussion with Professor Darcy Harris, Professor Liz Lobb, Professor Robert Nehmeyer, and Professor Andy Ho, moderated by myself, Paul. So we will begin with a 45-minute focused discussion, and in the final 45 minutes, we will open the floor to the audience, and all participants at this point in time are encouraged to really post your questions into the Q&A window on your Zoom browser. You'll find it at the bottom of your Zoom browser. And you're also able to upvote the questions of your peers by clicking on the thumbs up sign. So if you feel that question is something you want answered, please do not hesitate to click that thumbs up sign. So due to time constraint, we will only be able to answer the most popular questions with the most upvotes as decided by all of you. So please do not miss this wonderful opportunity to interact with our speakers, post any questions and reflections that you may have, and we look forward to this segment at the end of today's program. So one more thing about your viewing window, as an audience, you do have the option to change the size of your viewing window for the presentation and the presenter. So please go with what's most comfortable for you. So thank you so much, panel members, for joining us today. Can I ask everyone to unmute themselves, please? Thank you so much. So I hope that you've been having a great symposium experience so far.
Yeah, it's been great.
It's been wonderful. All right. Okay. So let's really proceed to the panel discussion. And the first question that I really have, it's really about the terms of dignity and compassion, which is really what this whole symposium has been about. So now it's really important that we're able to contextualize these terms well, as holistically as possible. When most practitioners think about dignity at the end of life, concerns often revolve around the dying trajectory, while dignity in bereavement is sort of seen like as an afterthought as well. So how do you feel the experience of dignity and the action of compassion differ from pre to post-loss?
Well, I guess one thing that I would say as someone who specializes really in bereavement more than in end-of-life care is that anything that we are able to do, say, practice, ritualize, that honors our loved one, that treats them with dignity, also helps us in our grief. And anything that dishonors, forgets, marginalizes, trivializes their relevance to our ongoing lives, it hurts us in our grief. It creates a kind of relational rupture, in a sense. We feel we've done poorly by them, and we have. And so I think that the contributions made by something like the FDI that really confer dignity on the patient at the end of life, engage the family, can be so helpful in bereavement. And I hope that you're able to conduct the kind of follow-up research that documents that effect.
Okay, so Prof. Ho, having been pretty much the developer, creator, and practitioner of FDI, what do you think about this?
I very much agree with what Bob has said. I think if we're able to provide the holistic care that patient needs at the end of life and provide them the opportunity to reflect on what's meaningful to them, and so they can leave this earth with dignity, I think that type of memories and that type of experience can do wonders for families, for surviving families who are going through the grief and bereavement as the patient passes away. I think in our clinical experience locally, a lot of our families who've gone through the FDI and who has patients or spouse passes away, they always go back to the memories that they shared. They always go back to the document and being able to reflect and cherish those good times and be able to, remember not just the sadness of dying, but a life well lived. That provide a lot of comfort for them. And I think we really, I think, looking at the whole process of palliative care and bereavement care, I think we're still very much compartmentalizing these cares. We're focusing on efficiency and effectiveness, where we're instead of integrating all these cares together. And I think if we are able to look at anticipatory grief and while the patient is still with us, and then providing that type of support continuously with the same care team, I think it would do a lot of good for patient and surviving family members.
Okay. All right. So, so that's thank you so much for sharing that. And you did mention the term anticipatory grief, Prof. Ho. And I think that old age and infirmity are really the ceremony of losses, right? As stated by this American poet, Donald Hall. And we see terminally ill patients often suffer all these periodical losses, from the functionality that they have to the social roles that they hold dear. Perhaps they cannot be, a loving and doting father anymore. They just do not have the time, the energy, or the drive to do it. And Prof. Nehemiah, you mentioned the other day very beautifully that meaning is the bridge from suffering to significance. So how then can clinicians, who I think are a majority of our attendees today, compassionately help patients and families make meaning of such non-death related losses?
Well, I think the very first step is to name them and claim them, that we cannot grieve and receive social support for that grief if we haven't acknowledged the loss. And often we lack the concepts, we lack the words. And so it is that, this is something in which Darcy's comment would be quite valuable, because with non-death losses, often they have a quality of ambiguity. They almost exist at a level beneath language. We have no cultural forms and rituals for acknowledging the difficult transition or passage that people go through when they move from health to illness, or from illness to greater progression of that same disease. All of these are very unwelcome transitions, and they can occasion grief, but they have no conventional markers. They have no clear endpoint. They can initiate a long period of chronic sorrow in the face of ongoing uncertainty. And so I think the very first step is to help people grasp, in some way, wrap their hearts and minds around what's happening, to have language for it, to acknowledge the significance of it. And the final thing I'd say about that, before yielding the floor to others who might be more knowledgeable, is that a lot of times we focus, I imagine, in the end of life period, on what we fear we will lose with that person's physical presence in our lives. And, I'm tempted to turn that question on its head. That is, what are we losing now by focusing on what we fear we will lose then? Often what we're losing now are precious moments of deep meaning making and living together, reviewing a legacy, sharing it, and maybe conferring forgiveness and so on, and requesting it for breaches in our relationship or disappointing interactions. So those are a few preliminary thoughts, but let me yield to someone who knows what she's talking about.
So I guess, Prof. Harris, that sounds, right up your alley. So what do you think?
Yeah, it's been punted my way, right? I'm thinking of many things as we're talking here. I'm thinking of also Ken Doka as he talks about anticipatory grief, and how I appreciate what he shares is sometimes what we're calling anticipatory grief is actually the grieving the losses along the way. That you grieve the anticipating the loss of your loved one to death, but today you grieve the loss that they don't recognize you, or they can no longer get up and move without your assistance, or they can't eat, or they don't want to eat, kind of the litany of the day. And so he talks about that, where we might call that anticipatory grief, but there's real grief happening on a daily basis for many of these patients and families. In my practice, anecdotally, I'll do this, there's cleanup. If patients and families have had a difficult experience with the care team, if they have not felt they've been treated with dignity, if they feel that they have been rushed through a system or have been overlooked, then that's something that comes into my office in the bereavement chair. And there's a lot of time I will spend with family members, what I call doing cleanup for that, because it leaves a lasting image, it leaves a lasting sense of powerlessness and often shame for feeling like they were trying very hard to be heard and they were not being heard and they were being seen in a negative way, and that compounded what they were already going through. I don't think we look at dignity as an afterthought in bereavement. I think it's a direct line that the experience of what a family goes through and loved ones go through as their loved one is declining and facing end of life carries right over into the work that they do as they're grieving after the person dies as well. I don't think you can separate those two things.
Okay. So I remember, Prof. Harris, you said that, that there really is no immunity to this kind of suffering, right, yesterday. And you talked a little bit about how caregivers might handle this, but what about clinicians? What are some implications for people who are directly working with this population of people?
So one of the reasons I got into looking at compassion-based therapies and work was because of the research about the sustainability of the compassionate stance. That really dovetails onto the ability to not detach, but to be able to take a step and look at the bigger picture. It's so easy to get so immersed in as a clinician and caregiver because we want to help and because we are empathetic, that it's easy to merge into the situation, and that doesn't really help the family. It doesn't really help the person that you're trying to assist. So there's got to be a way of balancing your empathic capacity with the ability to take that step back. The word detachment is the one that's used, but I don't like the connotation it brings up because I don't think disengagement or detachment means you're not engaged. I think it means that you are not hooked in, that this has to be a certain way. You are focused on being fully present, but you are not focused on it having to be a certain way. I think it takes practice. I mentioned yesterday about finding your own way of getting into a habit of being able to do that. And I was actually looking for the diagram of the tree of contemplative practices before we were starting, because I think there's a myriad number of ways that each of us finds to do that and to practice that in our daily lives, because if we've got the habit of knowing how I can feel myself getting pulled in, and I automatically say, what's the bigger picture here? I have the ability to respond rather than to react. And I catch the triggering that pulls me in to immerse me in a way that would be not helpful for the people that I'm trying to help. And this is, I think the compassionate base is not just something you learn in your head. I think it's a part of a practice of learning how to be with yourself and be with life and be with others and also be with your clients. It's not like you turn a switch and this is who I am professionally. Who I am professionally is an extension of the work and practice I do in my daily life as well. So it doesn't become something that's artificial, it's an automatic extension. And I will counter this too, that I think it doesn't make situations that are not safe or situations that are not tenable to be okay. I think there's still, episodes of moral distress. I think there are still places where people in caregiving are being asked to do way more than they should, or they're really capable of doing. And this isn't a way to excuse that and to make it all okay. But it is a way of coming to terms with, in this moment, how do I need to be? Do I need to change what I'm doing? Do I need to move on to a different position? Can I do this with these parameters in place? It's a way of framing how I need to be in a given situation, not being okay with everything that comes my way, but being able to gauge it in a way that's congruent with my values.
Okay, so thank you so much for sharing that, Prof. Harris. I think you've given the clinicians joining us today like a lot of insight from that. Being able to be away from that. So, Prof. Lob, what would you like to say about this? Given your immense experience in the palliative care field.
I would like to take the conversation back a little further. We know from the research that lack of preparation for the death can be a risk factor into bereavement. And sometimes there's confusion around the terms. We have palliative care and we have end-of-life care. And for a lot of people, palliative care is seen as the last days and hours of their family members' lives. And end-of-life care is a much longer period and a larger concept of that. And there's such a thing as the surprise question, which some of our clinicians may well be aware of. And it's simply, would you be surprised if this patient, this person in front of me, were to die within the next 12 months? And if the response to that is yes, well, then you really do need to start the conversations, the preparation. And as has been alluded to, the more that the preparation that could be done before the death, this can lead into benefits into the bereavement. And so this really opens, I think, a much larger concept about having conversations that are difficult. There are cultural aspects about these conversations, particularly around disclosure of prognosis. But I think if we're really going to focus on compassionate conversations, dignity care before the death, that this is a precious time when we really need to, while the patient is able, has the energy and perhaps the physical capacity to have these discussions. And I'm not just talking about an advanced care plan where you might tick a few boxes when you get admitted into an aged care facility or into hospital. It's about having really meaningful conversations about what do I want to do in the time that I have, what do my family, what are their needs, preparing for the family after my death, having those conversations. And sometimes families need help to facilitate that. They need someone to sit with them, to spend time, to some extent look at what's important. And I think that's where dignity therapy has played a big role for people to be able to reflect on their life, to look at what's important, to look at the messages, the legacy that they want to leave, the generativity aspect of dignity therapy. This is also true of other interventions that we may use. We're getting an echo in my voice. Maybe it's because I'm way down under in Australia. But all of these interventions, be it biographies, conversations, and I think this can be really challenging for clinicians to find the right time, because there's certainly, and this comes out in the literature, there's certainly a belief that if we have these conversations with a patient and their families, we're going to take away hope. And I think that we need to challenge that. We need to really be in tune with our patients and our families to know what is it that they want. And it's not about giving them everything and all the information now. It's timing that, it's tailoring it, it's individualizing it. But I think we need to think more of end-of-life care rather than those last days or weeks or hours before the person dies, because this is the time when so much of the preparation for death, which can then, as Darcy has alluded to, flow over as being supportive to bereavement.
To follow up on what Liz says, I think I can't agree more in terms of the way that we're doing advanced care planning or advanced medical directive nowadays. I think we started with advanced directive, which is very much checking boxes in terms of what you want to do, and we progressed from that to advanced care planning, which we focus on conversation and understanding what patient needs and concerns are. While that is very much the driving force behind the idea of ACP, in practice, it seems like we're going back to where we came from. It seems like the conversation is still very unidimensional. It's focusing on the medical concern, it's focusing on what you want in terms of care, which is important, but we're often neglecting the decision of care comes from relational consideration. It comes from what I want from my family. It comes from what I want for my son or my daughters or my spouse to not have that burden to decide for me. And I think, if you look at regional or even local context and how ACP has evolved, we are still very much looking at that model of efficiency. I think in the local context, we're now developing videos to teach people about ACP so we can minimize the time that we need to engage with patient. That really goes against the original or the fundamental concept of engaging patient, talking to them, understanding their lives, and therefore identifying the needs. How do we, I just throw this idea out there for all of our panelists. How do we balance between the need for efficiency, which is so prominently rooted in our society, when efficiency is the least thing that's probably in the patient's mind in the final days of life?
I guess really like how the paradigm can shift. Prof. Nehemiah, please.
My experience with this has to do with family members who I've accompanied at the end of life, and occasionally patients of mine, clients of mine who are themselves dying. But more commonly, I'm confronting these things in the context of bereavement care. And what both of these contexts tend to persuade me of is that the efficiency of our intervention is a function of its depth. That when we move to that place of truth-telling, of deep listening, of compassionate engagement, a lot can happen in a short time. Mm-hmm. And when we dance around that at superficial levels and avoid the big questions and so on, then the intervention can be interminable and still have no impact. So I would say move to depth. Do so as quickly as one respectfully can. Listen to what the client or family is willing to engage and have the non-anxious presence to go there and accompany them in it. And in that, I think we're not, one place that I encounter this is, in therapy, I have the luxury of spending hours across a period of weeks, months, years, and in a few cases, decades with clients. And if they want that kind of life consultation, that's a luxury in any hospital setting. But what I'm regularly persuaded of is even in critical care facilities and urgent care, emergency care, a few well-spent minutes that really humanize the family and the patient just can, be equivalent to the impact of several sessions of psychotherapy following the death. So again, I'd say go deep. And don't worry about the length of the intervention as much as its profundity.
Okay, Prof. Lob, I see you nodding along. Do you have anything to add to that?
Yes, I just something came to mind, a very powerful experience that I had with a patient that I was seeing. This woman had multiple myeloma, and she was really well. She was really well. And the clinicians had suggested that she might consider an autologous transplant to stabilize her illness. And we had a lot of conversations around this and what this might mean and looking at the risks and the pros and cons. And she decided that while she was well, that she would go ahead with this. And the next time I came to see her, she was unconscious in ICU. The procedure didn't go well. And I remember her daughter came in with a photo of her mum at her 50th birthday. And she was there with her hair done with a glass of champagne in her hands. And she put that picture above the ICU bed. And that was her way of saying, this is my mum as I know her and I remember her. This person who's in this bed with this medical condition or these medical dilemmas that are happening, this is the person. And so I think it's really important in our care that we see the person and not the illness. And I referred to this, I think, earlier on, which is where even to some extent the patient dignity question comes into our care. It's brief, what do I need to know about you as a person to take the best possible care? And we know that people struggle with that because they're so used to being asked medically, have your bowels open today? Are you nauseous? What's happening with your weight? So to think about, what it is that's important, and that's where we bring dignity into our care, but it's also where we bring personhood. And it's where we see this as an individual and we start to understand, because one of the things that can happen, and certainly in Australia, things are changing in our palliative care services. We tend not to have hospices like we used to. So it's not unusual for a patient to come in and to die 24, 48 hours later. And that's really challenging for our clinicians to get to understand that person and that family. More and more people, particularly in the time of COVID, are choosing to die at home. And then they tend to come in either when the symptoms can't be managed or carer fatigue, so they come in for perhaps those last few hours and days. So I think when it's not possible to have these verbal conversations, this is when our care and the compassion of our care, and it can be very small gestures that can acknowledge that person who is present in that bed and that family. And I think that's important. We need to be moving as our practices change. Our average length of stay is perhaps 16 days. But our nurses tell me that more and more people are coming in and dying 24, 48 hours later, which is very challenging for them to understand the family or to know what this person's journey has been up until this point. And I think that's where we can, in our care, in the simple turning down of the bed, in continuing talking to them, telling them what we're doing, asking permission, calling them by their name. Small things, but they make such a difference in preserving that sense of dignity.
Thank you so much for that, Prof. Lob. So I'm very glad that you did mention that, that practices are changing. And you also mentioned, I think it's hard to go a day without mentioning the big term now, which is COVID-19. So really, I do want to bring the discussion to something a little bit more current. So with the advent of technology, virtual, right, is now this global watchword. Everyone's using it every day, all the time. So how can clinical interventions translate in that sense into cyberspace? So is there a place for them? And are they sustainable, especially with regards to dignity and compassionate care?
I heard a conversation about that yesterday morning on the radio, where they were having a panel discussion about telehealth. And I know here in my local health district, we have been trying for years to get the health administrators, even to get us a web band that was broad enough to be able to have telehealth. Suddenly, COVID-19 pandemic came, and overnight, we suddenly have the ability to do these teleconferences. We now have the ability to have iPads in our palliative care wards. We haven't totally stopped visiting, but we limit the number of visits. But patients are able to have conversations with relatives interstate, because we do still have state lockdowns, or even relatives overseas. And so it seems that, yes, there's the opportunity for technology to be used, and they're also talking with general practitioners. I think you call them primary healthcare clinicians. And they were saying, I wouldn't become a doctor if my life was going to be spent on a telephone or on a television screen with my patient. So I think there are times when this sort of technology can work. Our own bereavement counsellors here are saying the ability to create that sacred space, and that's their language, the sacred space that you create when you're sitting one-on-one with someone in a room, that hasn't been able to be present during COVID because they've been doing telephone conversations. they find they're more tired at the end of the day because it takes more energy. You haven't got the full body language to be able to. You haven't got that to and flow of the energy. And so they're finding they're needing to concentrate more. They have less energy. They perhaps need to see fewer patients. So whilst technology, I think, is wonderful and it's improved our lives greatly, and particularly during the pandemic, I think we need to be careful that it doesn't become, again, another tick box. Oh, we can just bring the phone or we can bring an iPad. That we continue to hang on to that human touch, that human presence, and definitely in the work of palliative care and bereavement to maintain that sacred space for however short or however long that period of time may be.
Liz, let me push back against that just slightly.
Please.
But it's very much in the spirit of what you're saying, but I want to challenge the default use of technology thoughtlessly, without creativity, as a bleached out version of the fuller embodied human contact that many of us, of course, would prefer. But imagine this now. Let's go back to 2019 when most of us were seeing our clients, and we would see them if we're doing therapy, we see them in therapy offices. And what if, in that context, we can imagine ourselves in the office sitting across from a patient or client, and magically behind them would appear elements of their home setting. We could look at Liz, who's come to see us in therapy, and we can say, Liz, isn't that a Picasso on the wall behind you? Is that a piece of art that you chose? What's the meaning of that for you? Or Darcy, there's such interesting kind of painting. It looks like sponge painting on the wall. Is there a story behind that? What if we could use this magical window on people's lives and invite people, even, this is my study, and could you, Bob, show me, you want to take me on a little bit of a tour of your room there and show me what's significant for you? Wouldn't that be a special contribution to make? And what if we didn't do the default option of placing our laptops on the desk and having this kind of conversation up people's noses? What if we really took care to adjust the height of the camera to have an eye-to-eye conversation with people? What if we chose to look at them in the camera? I mean, there are so many things we can do to enhance the humanity of the interaction if we approach the technology thoughtfully and creatively. And the more I have tested myself and my limits, the more I have found that I and my clients nearly always are willing to go very deep in this medium. For one thing, we're really face-to-face with them. We can be quite close. And we can invite them to, move the camera a little closer, for example, as close as they're comfortable having it. In all of these ways, and many others, I think we can invite people to close their eyes with us, just to take a few mindful breaths, and with this, release all of the chaos of their day, to move into a place of silence, attention, awareness, as we just asked the question, what now has importance for me to raise in this session? And I do it at a quarter that speed. And then as we open our eyes now, Liz, what rises up in you is the thing that really needs to be said at the beginning of this conversation with me. And again, we can humanize, we can use this medium. It's not to say it's interchangeable with face-to-face, but we can use it a lot better to create just the sacred space that you're talking about.
I like that, Bob. I like it very much. And it reminds me of a story that one of our bereavement counselors, in the very first week, when he was doing a consultation with a new client, he hadn't met her before, and she had her iPad. And her baby had died. She came in one morning and the baby was dead in the cot. And in the consultation, she took the bereavement counsellor up the stairs. She said, I'm walking upstairs now. I'm standing in front of the nursery. I haven't opened the door before. This is the first time I've been able to open this door. And the bereavement counsellor, he said that was such an incredibly intimate and powerful moment through an iPad where this woman whose baby had died in that room and she had never opened the door before. So if that woman had come in and sat in the office with the bereavement counsellor, that wouldn't have happened. And so you're absolutely right. But we're sensitive bereavement counsellors, Bob, and then when you get out there into the big, huge health system, I think we do have to keep reminding people that technology is not a quick fix, and we do need to keep our heart in it. Yeah.
And the risk is that we move into a psychoeducational mode.
Yeah.
It just becomes an intellectual exchange and advice giving, quick assessment. And we trivialize the possibility of change when we do so.
So, Prof. Harris, do you have anything to add to that?
Oh yeah, I'm sitting here on the edge of my seat here. I've been delightfully surprised and have found the interactions with my clients through Zoom it's been a lovely opportunity. Like Liz is describing, I've gotten to meet my clients' dogs and cats and to see things in their houses that they want to talk about. It's been, and I actually forget that we're online because we can so engage, which has been lovely. The hard part has been during COVID that some of my clients, everybody's in the house. And so they have a hard time finding a private place to talk. Had one client that all of her grown children came home during COVID. They were all in university. And she had a big house, still the family home, but she had purchased another house for a rental, but she hadn't rented it out yet. So she would go over to the rental in an empty place, close the doors, and that's how she would be able to talk with me, because otherwise she would not have privacy in order to do that. One other thing I'm hearing too from our clinicians is that this has really freed them up, that our system our healthcare system doesn't typically reimburse physicians and clinicians to do phone consults and to do, you have to be in person. And now with the changes that have happened and since the measures for COVID, physicians are getting reimbursed for doing phone consultations or for not having to have patients come in just for refills and things, and it's freed their time up. It's also been a way that they could meet the needs of people who live further away, who for driving in to a clinician's office is much more challenging, especially if they don't have access to good transportation. So I think the limitation is if you have clients and people who are on the other end that aren't comfortable with using technology, they need somebody to walk them through it, or they still, despite the fact that it's there, they still feel it's artificial. So I think it's not going to be 100% for everybody, but it has certainly opened up doors in many different ways. So I actually think my practice will change now to some extent, that I will be able to, because I've never really used video conferencing for my clients before. I always wanted to see them and be with them because I thought I depend so much on my intuition and following their expressions and body language. I didn't know that I'd have that, and I do. And I have been pleasantly surprised by this. So this gives us another option for some of my clients. My office has stairs. Some of my clients have a hard time navigating stairs. This might be an alternate arrangement for them as well.
I think Darcy brought up a really good point about, technology can be used in a very wonderful way, but at the same time, a lot of our clients or patients or even family don't have that privacy at home, especially in the Asian context when homes are so small. We don't even have breathing room when everybody's back home. So that can pose a challenge for using technology in such a way. And to extend this conversation further, I think with COVID-19 and the social distancing measure, when death actually happens, we no longer can attend funeral as a group event. Some of us are limited to 5 people to be physically present, and the rest of us needs to be at home and watching the screen and just, there is this great sense of detachment and not being able to complete that ritualistic action that is so important for us to go through in that process. So I wonder for our panelists, what do you think about this change in the way that we engage in funerals and because of pandemics and future pandemics?
Well, just to quickly respond to that, I think the same principles apply, what we're speaking of earlier, that we need to move out of the position of being viewers and into the position of being doers. So even if we are watching that memorial service on a screen, let's turn down the lights. Let's light some candles in the room. Let's create that sacred space. Let's sit there together as a family and witness this with the appropriate solemnity. When the service is over, let's turn to one another and take an hour for sharing a story about grandmother or father. Let's remember some good times. Let's record those conversations, right? And then let's adjourn to a family dinner where maybe we cook a dish that grandmother used to prepare for us, or one of Dad's favorite foods. And so we are participants in the construction and performance of ritual. We are not made helpless and merely cast as bystanders to a kind of faceless, impersonal event. We're simply challenged to step into it in a way we can. And maybe the young kid in the family plays the musical track that softly accompanies us in the background as we share the stories and so on. So there can be a role for everybody. And when we, consider dignity conserving care to extend to the memorial service and beyond, then we're really taking that ethos that you're cultivating in the death room, and we're taking it into what follows.
Right. Okay, thank you so much for that, Prof. Niemeyer. I think let's move into the next section of our panel discussion. So I really do want to open some of the questions to the floor as well. So let's start by answering some of the more popular questions in the Q&A box. And thank you so much, attendees, for writing in your wonderful questions, stating them so beautifully, and also upvoting each other's questions. So Chaigan had this to say, and she goes, "Dear panelists, I have a question to seek your wisdom. How do we integrate the various therapies and approaches for end-of-life patients or clients we meet in a community setting, so versus clinical settings? So basically, what are the differences and what challenges might be present, and how can we overcome this from a community versus a clinical setting?" So maybe
I've spoken too much, so I'm just standing back to make space for others.
Okay, so Prof. Ho, maybe you want to take this question with regards to how we can.
I think there is, with the development of home care, palliative care, I think, and home care, hospice care, I think that we moved a long way and developed a whole spectrum of services that really are enabling us to move the care away from the acute setting and into the community, into the homes of people. And to be honest, in hospitals, their mandate is efficiency. Hospitals are supposed to heal you and get you walking out of the door as soon as possible. That said, I think there could be a lot more collaboration and interagency support, whereby when we engage a patient in discharge plan, we can have that level of collaboration with community service organizations, with NGOs, with VWOs, so that when the patient is discharged, there is still a linkage with the hospital. And there could be home care support team that goes into the homes of patients and provide them with that type of support. In fact, I think because the efficiency mandate is removed once you move out of the acute hospital, we can actually spend more time with patients and families.
Oops. Okay. Oh, I think Prof. Ho.
Could he be muted?
Yeah, I think. Oops. Prof. Ho, I think your mic blitzed out a little bit over there. Yeah.
Okay, I think this is better.
Okay. Yes. Yeah, it's better.
There's great opportunity for home care team to spend more time to really realize the dignity and the compassionate component of care, because they're not limited by the efficiency mandate in acute hospitals.
Mm-hmm. Mm-hmm. Okay, so Prof. Lob, what do you think about that?
Yes. I think a lot of what Bob has been referring to, we can have in the home, and Darcy as well, a much richer environment. You know, you've got the family dog, you've got the cat on the bed, you've got freshly picked flowers from the garden. We developed a process with our community patients, because we have over 300 patients at the moment in our palliative care community service, and we called it patient-centered family meetings. So as opposed to the family meetings are often held in the hospital where the doctor will call the meeting, it's usually due to a clinical concern. It might be to discuss discharge or transfer to a residential aged care facility. So with our patient-centered family meetings, we ask the patient to set the agenda. So the patient decides beforehand what questions they want. The patient decides which family members they want to be there. We also have one of our community nurses to facilitate the meeting. If there is a need for the oncologist or perhaps their general practitioner to have input, we bring them in by telephone. And so we've been able to transfer what's been essentially a hospital model into the community. And this has worked really well. And when we evaluated it, the clinicians were really surprised at the questions that the patient put on the agenda, which was so different to what would happen in the hospital setting. And so much of what was on the patient's agenda was about, you know, my family, or I'm concerned for my son, or I'm wondering what will happen with, you know, for someone who was worried about a particular family member, what's going to happen to them, or how will my family be after I go, or can you make sure this happens? So their questions, even though they had the opportunity to have their oncologist, to have their general practitioner, their questions were very much about, the majority of the questions were about family, an opportunity to give thanks. You know, I want to take this time now that everyone's here to be able to say thank you for being with me, for the care you've given me. And one of the key findings that came out of our evaluation of this model was that everyone had a sense that we were all on the same page, because we were all hearing it at the same time from the patient, what their needs, what their expectations were, what messages they wanted to give to the family. And it really allowed us to tailor our care and to anticipate what might be needed next. And we're in the process of writing that up. I have a PhD student who's been testing the model, also in the hospital setting as well. And so I think, as Bob said, we can be creative. We can really make this centered on the patient and their family and their home, because we're on their territory. To some extent, this is on their terms, whereas when they're in the hospital, it's on our terms and it's on our territory. So I think it can be a very rich opportunity to be creative.
Okay,
I
so
don't know what Liz have said. I think what I've observed in different countries that I lived in, the roles of different types of clinician also comes into play. So for example, in many Asian society, we have a clear structure for physician, nurses, and social worker. But beyond that, there's no professional regulated or registered role for a counselor. And I think whereas in the States and Canada and Australia, there is a professional role for counselor. And that makes it so much more easy for patient to receive that type of psychosocial care. Because right now in a lot of Asian countries, we're relying on social workers to provide that type of care. And while they may have the capacity to do counseling, it is really not in their training. And I think that type of structure in terms of social care provision, we need to be able to delineate it a lot clearer for that to transpire.
I think this moves us very nicely to another question that we have from an attendee. So Pei Ling, she asked, what could be some ways that we can influence practitioners to move away, either gradually or transitionally, from the medical model itself? And whether or not we could provide patient-oriented approach such as dignity and compassion models within this Singaporean context as well. So moving really away from that major paradigm of the medical model. What do you think about that, Prof? Prof Ho. Prof Ho. I should probably direct that a little bit better, yes.
I think that's a great question. It's the million-dollar question: is how do we move away from the medical model, which has been ingrained in our mind and our hearts for the longest of time? I think that starts with education. I think that starts with even in the early days of medical training or social work training or nursing training, that we need to incorporate the biopsychosocial model into it too. I mean, if you look at the training, just simply life and death education, we don't really get that at all in our medical training. I think some research come out of the United States that within a 5 or 6 year medical curriculum, doctors get maybe 10, 20 hours of life and death education. In Singapore, I think there is medical humanities, but medical humanities is really like a 1 session or 1 day or 2 day training per semester. And that's just really not enough. Bob, you may have something to say about that, I would imagine.
Well, what I would say is just shaped by my experiences over the past 5 years or so, providing training through the Portland Institute in Singapore. And I've had the opportunity to work with hundreds of people, and quite possibly a large percentage of the people who are watching today are folks I've had the chance to work alongside in intensive trainings of 3 or 5 days each time. And what I find is that social work does constitute the largest single discipline. And I am very struck by the humanity and readiness and willingness of the people from a variety of psychosocial professions and sometimes medically oriented professions to really earnestly take part in experiential training, to apply the concepts and methods that we're teaching to themselves and their own losses as a precondition for understanding how it might play out and, when offered to family members and patients. So I just believe that oftentimes continuing professional education can compensate for the weaknesses of graduate education or professional education pre-degree. And maybe that's as it should be. Maybe the goal of professional education is to get us ready to engage in lifelong learning. And then we ourselves are better oriented to recognize what we need and what we're ready to expand into. I actually wondered for Darcy as well, because she has the unique experience maybe among us on the panel. I don't know enough about Liz's pedigree, but she began as a nurse and became a psychologist. So she herself underwent the very transformation that Paul was inviting us to consider, from a medical model to a more humanistic one in a way. And I wonder if you can say anything, Darcy, about what prompted you to make that change.
Oh, okay. So we're going to talk about one of my non-death losses here, because I loved being a nurse, and I worked in oncology for many years and also transitioned with patients into palliative and hospice care. So what happened is when I moved into a new area, how cancer care and hospice care were organized was based on the medical model very specifically, and also very much on clinical trials and the emphasis on research grants and the money coming in from research initiatives. And I struggled because I felt that some of the patients, especially when I was in the chemotherapy areas, were not being asked what was important to them. That it was just assumed that you'd want to treat, and this is how we're going to treat this. And they really didn't have an understanding about the impact of that treatment on their quality of life. I sat with one patient. He'd had colon cancer and had been treated, for adjuvant, thinking that they'd gotten it all. And then he ended up with liver mets, which is not something that's curable now. So we're into contained palliation. And he came into the chemotherapy area. I was working as a nurse that day, and I was assigned to do his chemotherapy. And he said, what I'd really like is I want to go see my daughter and my grandchildren in Australia. I want to see them. I know she's not going to be able to travel to see me. And I knew that as we started this new regimen with him, that the side effects were going to be significant and he would never get that opportunity. And there was no place for me to go with these types of concerns at that time. And after a couple of incidents like that, I left and chose not to actively be in nursing anymore. And that kind of started me on the path of going into counseling psychology, really made me start looking at my own personal practice and beliefs, how they would be applied into a clinical area. So it was a very difficult choice for me to make at that time, and one that was very much based on, I don't think I can practice in this way and maintain my own sense of personal integrity. That doesn't mean that the nurses who stayed compromised. It was just for me to do this type of work, I knew I had to have certain things in place, that I had to feel like I was being supported to do my work in a way that was congruent with my values. So that was a non-death loss for me. What I find is the medical model has so much privilege given to it, and so much political, social privileging to it. The funding sources, the decision-making, the setting of priorities. And I think that worked for a long time, but it's not working for us now. It's sort of like how ICUs got started, you know, in the 1970s, 80s, and they were life-saving for people at that time who came in and who could be mended with this intensive care. And now we've got people in their 80s and 90s coming in, and they can't be mended in the same way, but we still put them into ICU because that's what we do. So I think there's a lag behind what our populations need. We have an aging population in all the countries that we're sitting in. Even thinking earlier, this conversation about dignity and dignity care, and it's time consuming, and the efficiency model, and we're going to be facing bigger numbers of people needing intense end-of-life type care and this type of discussion. We're going to have to diversify in order to meet those needs. So I work my way through my writings, and when I'm asked to present to groups, well, I know there are a lot of medical people or people in healthcare, to try to throw these ideas out just for consideration. I go back, the UK actually introduced, after they had a huge upheaval of their healthcare system several years ago. If you go into the Scottish portion, they have something called What Matters to Me. You know, what matters to you. You can actually look this up. There's some beautiful videos on that. And so it's like what Liz was talking about, this question of what matters to you. What is it that we need to know? But instead of saying, what do we need to know, just what matters to you? And that's really not part of the assessment sheet that you're given when you have an interview with a patient. You do the systems review, and at the very bottom is any psychosocial concerns. And by that time, you've done a whole interview, you're at the end, you're pushed for time, and the patient's feeling like you need to leave, and that's not when they're going to start to open up. So I think it's a paradigm shift, and it's going to be hard. I also think it's necessary as well. And perhaps, people coming into the trainings like we're doing now, and the people who are opening themselves up to the professional development where they get exposed to different paradigms might be able to start this shift. It's going to be an important one to make.
Thank you so much for that, Prof. Harris, and also for highlighting, I think, a lot of the struggles that clinicians, especially nursing clinicians, face as well, which I myself am very familiar with, having married a nurse. So, yeah. And the next question is kind of really related to that as well. So Kelly asked, so she says that we've been targeting a lot of anti-story grief, compassion, and empathy on families, FDI also for caregivers, and how she has actively spoken to her nurses after an unexpected demise of one of their nursing home residents, and a majority of them were not able to accept the demise. And though her nurses knew that she was available to hear them, they seemed to struggle internally. And so Kelly asked, do we have separate tools or help for nurses, especially junior nurses in nursing homes? So really what we can really do to help these perhaps budding clinicians, yeah.
I'll jump in quickly. I feel like, Bob, I just taken up a lot of airtime. When I was in my nurses training, I got 3 hours of Kubler-Ross, and that was the extent of my exposure to handling death. And at the time, I mean, it was at least an exposure and a discussion. It was a 3-hour seminar. And one of my first rotations in nursing was on an oncology unit. And I'll never forget the first patient that I was caring for who died. I kind of walked out of the room and everybody was going about their business. And I remember thinking my world had just completely shifted, but everybody else was just going about their business as usual. So there's got to be a form of mentoring and a way of honoring the human connection that we have with our patients. It's not just the patient in room number such and such with this diagnosis. It is a person and it is a family, and you are a person. I think of in long-term care homes, especially, we form real relationships. This is their homes, and we are part of their home. And these relationships are very real. Just because a relationship is professional doesn't make it any less real or any less valid for grief. And often that gets misplaced, thinking that, okay, now we just go about our business. And we lose a little piece of our humanity in that process. So I'll step back and
No, that's really beautiful, Darcy.
Where Liz might be able to step in as well, because this is an area I'm sure she's had experience.
Yeah. It's interesting, Darcy. I had a recent experience which really made me reflect on the significance of ritual and why we don't do more of this. And it was my dog Pollyanna. And she reached the beautiful age of 18. And there came the time her hind legs had gone and there was no more that could be done. And I took her to my vet, who'd been caring for her since she was a puppy. And we went into the consulting room. And when I came out, there were 3 candles on the reception desk. You know those LED light candles that you can switch on? And there was a notice. The waiting room was full, but hushed. And the notice said, when the lights are on, someone is saying goodbye to their beloved pet. Please, can we keep our voices low? If we can do that in a veterinary surgery, how much more honour do we owe those who are in our aged care facilities? And you're right, Darcy, they are homes. And I think this is where ritual and meaning is so important, and to include the junior nurses, and not just the nurses. I mean, in our palliative care services, our kitchen staff, our domestic staff are coming into patient rooms every day. And they know that yesterday Mr. Smith was there, today Mr. Smith's name's not on the lunch menu. And so I think we need to think more broadly of the lives that are touched by this one individual. And certainly in our residential aged care facilities, it is a family. And so what would you be doing for another family member? And it could be as simple as lighting a candle in the foyer. It could be as simple as announcing the person's name at the evening meal to say, let's spend one moment thinking about. So I think ritual is so important as a way of acknowledgement for a life that has been lived and now has been lost. Yeah.
Let me just add a brief footnote to that. I had the privilege, I guess it was about maybe a year and a half ago, to be called on to consult with a memory care center that provided care for elders daycare. So this was not residential, but they got to know the patients typically over a period of many months, and were very connected to them and very connected to families. And they had no rituals or practices of any kind for saying goodbye or acknowledging the place of those patients in their lives when they died. They just, simply the bed was empty and then it got filled the next day. And so what I found is that I didn't have to provide the solutions. I just needed to ask the questions. And I suggested that we get all the staff together, and there was maybe about 30 people in this facility. And we sat in a circle, and maybe we started with a brief meditation. And then I asked them to center on the questions that they had about how they were dealing with the losses through death of people in their care. They began kind of quietly, and then some people started speaking more boldly. They felt guilty. They felt like they didn't know what to do. And then just as I gently prompted them to, how could you deal with this in a way that would be more satisfying, more human for you? people started to generate ideas and bounce them off of one another, and maybe I'd help shape them and invite a little more elaboration. And within an hour and a half, we had a whole kind of protocol. There was a small room near the break room for staff that they were going to dedicate to a special place where they would post photographs of the people who had died in the previous week. And there would be cards there for them to sign and write a note to family members. They'd send those out then on a weekly basis after everyone had had a chance to relate to them. They'd have a circle time just once a week where they would move into silence, and then they would say a kind of secular prayer, and they would speak the names going around the circle of each of the people they remembered fondly and had lost. And this was not something that took a great deal of time, but oh my word, it made such a difference. They felt like they were doing right by people. And of course, it enabled them to also speak to their own sadness, to claim that, to share sometimes a funny story or a memory. And so just the way that we'd expect with families, so too with staff, if we give them a chance to be human and to grieve, to acknowledge, to honor, to confer dignity on those who had passed through their care.
I cannot agree more with what all of you have said. I think being able to engage in ritualistic action can really help us to recognize the death that has happened with our patients. And as Liz says, it is really a family. They live there, this is their home, and we are part of their family too. And I think another thing that I really want to highlight is that in a lot of our institutions, as well as our VWOs and NGOs, and we have this great mission statement to provide compassionate care to our patient, right? It is really written in our mandate. But it's almost as if we have neglected the fact that the nurses and the doctors and the kitchen staff and even the janitors, they are human too. Can we have that mandate to be all-encompassing, not just for the patient, but for the entire organization, that we work in this mindset, that we need to be compassionate to everybody as well as to ourselves. Because one of the biggest challenges that we see internationally, locally, is that high turnout rate of people who are in this industry, and they go in and they have a lot of aspiration, but within a month, a year, or half a year, they're completely burned out because there's no way for them to find a way to release their emotion, the sadness and the grief that they experience. And so having that ritualistic action, that practice, and even some self-care techniques training could be very useful. And when I talk about training and education, I think a lot of people see training as sitting down in the lecture and listening to a person speak for 5 hours. And I think Bob talked about the importance of experiential learning, to be fully engaged in your training, to be able to practice what you are taught, to change that cognitive knowledge into something that's practical and tangible. I think that's the things that we really need.
So, Prof, I do remember that you have conducted some work with regards to burnout, which you mentioned. So would you like to tell us, share with us a little bit more about that?
Yeah, so we developed a program called Mindful Compassion Art-Based Therapy. It's really integration of mindfulness meditation with expressive arts to provide a different medium for people to explore their grief and to explore their sense of loss, because we know that language sometimes can be very limiting. We don't have a lot of words in our language to express what really goes on in our mind, and we often don't find the right words to describe them. And so I think in Bob's session, he also talked about the importance of using different creative mediums, whether it's a photography, whether it's art or music or poetry, using symbolism as a way to help us reflect what's really going on inside of us. And that program has, we're still doing, we've tried that with professional caregivers, and we have some really good results. We're now moving on to work with family caregivers with dementia patients. And I think MCAT is one way, but there are many different ways to help people explore their feelings and to release them in a way that's constructive. And I think as healthcare providers or managers or center in chief and staff, we need to really take care of our healthcare team, because they are, without them being helpful and healthy, it's hard for them to provide quality care for patients on the other end.
So I really like what I'm hearing is really like, having that common humanity within the medical setting, right? And Prof, we actually have a question from an attendee that's directed at you. and it's an anonymous person. So they mentioned that you mentioned that we often concentrate on efficiency and effectiveness. And they ask whether or not you can elaborate on how there can be a balance with dignity in care, and whether there's evidence that this kind of emphasis actually contributes towards overall efficiency.
Well, that's a heavy question. I think it's hard for us to move away from that model, especially in the acute care setting. But it doesn't take away from the fact that, as Liz says, even the smallest thing that we do, whether we look at a patient in the eye when we speak to them, whether we remember their name as we call them, those are the small things that we can do in our everyday practice to add that dose of humanity to the care that we provide. And I think patient would and I think it's also important for us to realize that in this day and age, we focus so much on KPI. Do we hit our target number? A lot of these things that we're talking about cannot be measured through statistics. It's really about being able to embody the belief that we have. That we are a compassionate being, can be compassionate not just in the clinical setting, but in every parts of our life, like Darcy has said, and really transpire that within our professional life as well as the personal lives. Other panelists, what do you think about this need for efficiency?
I was just going to comment on the self-care. We have several programs. Every year, our bereavement counsellors run a memorial service, which is very common in palliative care facilities, and family members are encouraged to bring a photo, and it's a very moving ceremony. But the pastoral care workers came up with the idea, why don't we have this for the staff? Why don't we have a memorial service for the staff to remember patients, family members? And we didn't know how it was going to work. And so we've got a very creative director of pastoral care, and she went out and got a large gum tree branch. And she then made paper gum tree shaped leaves. And she got the staff, we held it at different times with different shifts as nurses were coming and going and staff were coming and going. And people would walk in and they would write the name on the gum leaf and they would tie it onto the tree. And we do this at Christmas time as well. We have a big Christmas tree in the foyer. We have a large basket of Christmas baubles, and staff and patients are encouraged, and family members are encouraged to write the name on a bauble and put it on the tree. Another very small, and this is coming back to this question of how do we take away the impersonal acute hospital setting, and this also was an initiative out of the UK by a doctor who herself became a palliative care patient. And she noticed that in a day, all these people would waft in and out and they'd do various things and they didn't necessarily have a uniform on. And so she came up with this program, which we've now instigated here, called Hello, My Name Is. And when you meet someone, and we're encouraged now to do it in the grounds, when we're walking through the grounds, between the wards, between the different buildings, we say, hello, my name is, and we have our name bag on. But it's a way of personalising, of introducing yourself, of putting a name to what you do. And so, big institutions, you can make small changes that are not going to cost money, that aren't going to suddenly revolutionise what we do, but it can make such a difference that we are recognising people, that we are starting a conversation that may only last a couple of seconds, but it can make a difference. And I just think ritual, no matter how big or how small, can be crucial to this.
Just to add to that point, Liz, I think what I've observed over the years is that institutions are now beginning to make use of different infrastructure. They're changing the way that perhaps providing a certain room that is ready for people going through their last hours of life, and that room can have every time we go for a home visit, we see a changing, rotating picture, whether it is a picture of a Buddha, whether it's a cross, and it provides a type of flexibility to respect the religious faith of people, which is wonderful. I think having those type of infrastructure in place is good, but it's still a hardware. For it to really realize its potential, it needs to come from people itself. And again, I can't stress more of how the individual becomes becomes the fuel or the trigger point for compassion to really be realized.
Prof. Nehemiah, do you have anything to add to that?
No, I'm just waiting for another great question. I'm so eager to hear what people have curiosity about.
Yeah, we've been having such wonderful questions as well. Okay, so this next one is really with regard to clinical and professional work. And this is also a question by an anonymous attendee. So they say, we learned that grief and loss is a common human situation and process that we have compassion for. So this would mean that all human beings go through grief and loss. So as a professional, how do we decide when clinical or professional interventions are required and when the family or individual can cope with the grief without interventions as well? So when do we step in as clinicians?
Well, I think we can ask the clients themselves that question, the patients, the family. How are you doing with your grief? What's the toughest part of this for you? What would help a bit with that? And then we just listen. We listen deeply for the opportunities. And what we might hear is, I think I'm doing pretty well. I was worried a little bit about my son for a while, but now it seems like he's starting to adjust, even with the death of his mother. And, I find I'm doing more things with him than I used to. And so we can reinforce what's going right for this family. But we can also listen deeply for the parts that still hurt. And, of course, we do know that sometimes people can get very stuck in a complicated and anguishing place in grief, and there can be a lot of a heavy toll on their physical health as well as their mental health and relational well-being. But that obtains in probably 10% of the cases, according to international studies. And 90% of the time, people, benefit from bereavement support, but they don't need professional therapy. We do need to be alert to those cases where after 6 months or a couple of years, people are still grieving as if it's 6 days or a couple of weeks after the loss, and they're not on a trajectory of adaptation. If anything, things are getting worse rather than better. And often secondary problems of substance abuse, alcoholism, family tension, and so on begin to add to the problems. So we need to be alert to the problems, but we need to be equally alert to the solutions that families are creatively implementing and reinforce the latter.
Okay, thank you so much for that, Prof. Nehemiah. So Prof. Harris, what do you think about that with regards to support?
I always appreciate hearing Bob and describe how he approaches this. I honestly do have some things I ask people if they're talking with me. I ask them if they're sleeping and how much they're sleeping, because it's a very specific place. If you're not getting more than a couple hours of sleep at night, and that's going on for weeks at a time, your body is going to wear down, and you're not going to be able to process the grief that you're experiencing. So that may not be something that requires ongoing intervention, but I will suggest that a person seeks help with their medical doctor and maybe addresses that with their doctor, because sleep is something that's not optional. We'll talk about different ways around sleep, but if you can't sleep, you have a hard time functioning. I ask if they're able to eat at least one meal a day, and I ask generally for them to describe their days to me and what they're experiencing. So I'm pretty concrete with those things. And I think that it's not just, there's about the 10 to 12% of people who really get into this very stuck kind of complicated grief. There's another group of people who maybe aren't in there, but who don't have support, or the support they have around them is unreliable, or the people who they would run to for their support are also grieving so heavily that they can't support each other. So it's not that they're coming into professional counseling or therapy because they're dealing with a complicated grief scenario so much as they need a safe place to process the grief. And so this is another place where I see sometimes referring or having a client referred to me who may have many family members, who may have good friends, good community support, but perhaps there's something they don't feel comfortable sharing in that circle. or perhaps there's just something there where they really don't find that circle of support is giving them everything that they need as well.
Okay.
I like that idea of focusing on the power of the collective, the power of relationship, because often we misunderstand resilience as an individual characteristic. It's like our personal hardiness or something, and that's far too individualistic, and maybe most particularly in an Eastern context, but really universally. We rely on others really to get through breakfast most days, much less to get through bereavement. And so I see myself not as the sage on the stage who's providing all of the answers to people in grief. I'm the guide on the side who's trying to help them mobilize their indigenous systems. And one thing that Ken Doka does that I think is really helpful is he will talk with people about different categories of support that they need. And so he asked them to, make up a list right there with him of people who are doers, people who are listeners, and people who are respite figures. And doers are the people who you can consult with to figure out what to do when your computer breaks down, or what happens when your lawnmower needs repairing if you live somewhere other than Singapore where nobody has such things. And listeners are people who, they may be terrible at fixing lawnmowers or computers, but they are willing to listen and they don't rush to give advice. And then there are respite figures, people who we can just hang out with and enjoy. And maybe they're terrible listeners, but maybe they're a lot of fun. We want to go to a movie with them, or when we're able to do such things, go to a restaurant or to the garden with Andy, see the super trees. So helping people figure out, who do I turn to? And let's make sure I've got a handful of people on all those lists, and that I turn to the right person for the right thing, that I don't go to the doers and then get mad at them because they're not listening deeply enough. Just to be thoughtful about activating our own webs of support.
Yeah, and I think that comes in with regards to a lot of contemporary social psychology theories that are coming out as well. The importance of connectivity and being a part of something that is an extension of yourself rather than just you as a primary node. Yep. Thank you so much for that, Prof. Nehemiah. Okay, so we've had we actually have a couple of questions on this big word, which is death taboos. Right. So we have a question by Chai Gan and also an anonymous attendee, and both of them really talk about death taboos. So how is it that we can go about normalizing conversations of death, normalizing things like ACP and end-of-life care planning, and how can we really get over this major hurdle of death taboo? So Prof. Ho, with regards to your international experience, do you have anything to share with regards to this?
I think I would actually leave the time for our international panelists. I've been talking about this in Singapore forever since I came here. So we would like to see some new perspective on death taboo.
Well, one small cultural contribution to this that's kind of interesting is the phenomenon of death cafes, which are offered in many cultural settings. And this is not a bereavement support group. It is not a group of people gathering where they're contending with serious illness. These are folks who are, doing just fine. They're well. They're not experiencing bereavement anytime recently, or nothing looming. But they get together in a cafe. They share a cake and some coffee or tea, and they have a conversation about death. And often the host will kind of prompt it with a question or a little activity. I remember going to one in February, and it was near Valentine's Day. And so as we were sipping our tea and eating our chocolate cake, we were invited to write a Valentine to someone we had loved and lost. I wrote one to my parents, both of whom had died. And it was a lovely kind of thing. And then we sort of shared and talked about those. And it wasn't a bereavement support experience, but it was normalizing the idea that people do die, and we find ways of moving on, and we can move on with them as well as without them. So I think that's an interesting way of trying to take it into the culture and out of the clinic.
I'm reminded of a Vietnamese monk called Thich Nhat Hanh, and he has this expression, "Call me by my name." And I think all of us have a role to call the person who has died by their name. When we happen to meet one of the family members in the street, how have you been since the person died? So, and often in eulogies, there'll be that poem about, I have not left you, I'm here, but it's about naming them. My brother-in-law died 12 months ago, and we had our first Christmas without him. And so we set a place at the Christmas table. We put a bauble on the Christmas tree with his name. And there were, children, there were babies, 3-year-olds, 7-year-olds, they all knew their grandfather. We talked about him. We talked about what he would do, and we called him by his name. If Uncle Terry was here, we'd be doing this, or Terry would say that. And I think it's so important in our death literacy to call people by their name. They have lived, they've been real, and in the hearts and the lives of their family members, they are still very present. And I believe that we can play in counselling, of course we do that, but I think as private individuals, members of a community, a family, a society, call me by my name. Yeah.
And I think with that sentiment, which was extremely eloquent and so beautifully put, Prof. Lob, I think we are a little bit out of time, so let's bring the Q&A to a close. And I would like to thank the attendees so much for their unbridled curiosity, and also to the panelists for your very, very generous responses. And before we log off for today, so Prof. O, might I invite you to bring this wonderful symposium to a close?
Thank you, Paul. I think it's been a wonderful 5 days, and it's everything good things do come to an end, so we must close the symposium. And I would like to take this opportunity to again thanks the Ministry of Education of Singapore for the generous support in the funding of the symposium through the Academic Research Fund's Tier 2 grant, the PalC Care Center for Excellence in Research and Education for hosting the symposium, to Liz, to Darcy, to Bob, for your very informative and inspiring presentation that have made this a very rich symposium. And of course, to all of our 620 participants for your enthusiasm and passion in learning about dignified and compassionate care. And we truly hope they can bring the knowledge gained from this symposium back to your professional and personal lives to better support individuals and families who are going through the great pain and suffering as a result of critical illness, death, and bereavement. As Liz, Darcy, and Bob and myself have shared that while mortality and grief can be filled with sadness and challenges, it is nonetheless a universal experience that we all face as a human species. And the practice of dignified care and support, we can make sense of them, learn from them, create meaning from them, and potentially attain to transformative growth as a result of our common humanity. Thank you once again for all your heartfelt support, and look out for our emails later in the month when these recorded seminars will be made freely available to anyone who goes through our PalC website. Do share them with your colleagues, your friends, your families, and we can all spread the seed of dignity and evidence-based practice in creating a more compassionate society to all of those who are facing the end of life. And finally, please do complete the short polling question that are being popped up on your screens now, as your views will help us improve our work in the future. Thank you all of our panelists. Thank you, Paul. Thank you, the PalC team, and thank you for our participants. Have a wonderful day, and I can't wait to see you next in our next engagement.
Thank you. Bye-bye.
Thank you.
Namaste.
Thanks, everyone. Go well.
Thank you, everybody.
Take care.
Bye-bye. We don't want to go.
I'm
not switching my microphone off. Everybody else do it first.
Well, it was delightful. It was a great week, really. I think that, Andy and Paul, you guys deserve a lot of credit for hosting this. That's been
Thank you so
a
much.
blast. And pull together.
And May and Lachlan from PalC team, you guys has been wonderful. Without you, it was so lost. We don't know what to do without technology.
Absolutely. Thank you.
Well, we're having an after party on the other.
Great. Good.
All
Thank
right.
you.
Okay.
Bye-bye.
Bye-bye.
Thank you so
Go
much.
well.